First of all, would like to thank Dr. Sudeep Gupta for entertaining a technology session in a scientific conference. I think we are going to see more and more of that. I want to cover three things. I'm going to talk a little bit about just the importance of digital health and what's happening at the national level. Dovetailing into that is the work that we are doing within the National Cancer Grid. We've now established a dedicated center for digital oncology. So I'll speak a little bit about what that center does. And then we'll talk specifically about some of the initiatives that are broadly on our roadmap, just so that you guys are familiar with some of the work that we are doing. But stop me wherever you would like to ask questions. I'll start with just the overall national digital health schema right now. I think many of you would have heard the Ayushman Bharat Digital Mission. The good news is that now digital health is gaining a lot of momentum as a national health priority. The work that the National Health Authority is doing, they're leveraging essentially what we are now familiar with, all the payments infrastructure, right? We all do GPay and Paytm, and it's second nature. We don't carry cash. The idea is to leverage that technology infrastructure and build what they're calling as the health stack. So we will all have a identifier for every doctor, for every patient, for every institution. Again, the intent is to facilitate the portability of health records, which today is not possible, right? When a patient moves from one facility to another, and especially in a condition like cancer where patients do move around quite a lot, moving with files is not a sustainable problem. When patients lose records, they are subjected to more investigation. So the idea is that when they move, very easily, based on what they are calling as an ABHA ID, which is much like our UPI ID, any other doctor or facility should have access to all of their previous records. Now, it looks very, very easy and good, but the problem is a lot of our healthcare data is not captured digitally, right? So while we can generate the ABHA ID, unless we have electronic medical records and some way of capturing clinical data, the only data that's available is mostly demographic, right, which is not very useful. So started with a lot of momentum. I think they're still kind of realizing that we will need a lot of work at the foundation level to ensure that much of that data, even if it's a minimal data set, is captured electronically. But there is hope. There's a lot of money that is put behind this as well. I think for a lot of government hospitals, it's starting to become mandatory. And so a lot of them are kind of rushing towards this March deadline of capturing at least that much data electronically. When we look at digital health broadly, right, in terms of cancer care, there is tremendous opportunity. I think some of you may have heard of some of these companies. There are a lot of organizations that are purely focused right now on artificial intelligence and machine learning to do image processing, right? In radiology, there are a lot of applications that are much more advanced. Pathology is picking up as well because much of that data is generated digitally. So it's easier to mine, both from a prognostic standpoint and even in some cases, even from a diagnostic standpoint. There are tools that are now having integrated clinical pathways. So depending on the data that you feed, it will actually give you a choice, right, as a doctor to say, yeah, you could take one of these three parts of treatment, and it's still left to you as a doctor to decide. The technology is not deciding it, but it's at least giving you what are all your options. Patient-reported outcomes, I think with remote monitoring and IoT, it becomes very easy for patients to enter data into their smartphone, right? We have so many apps now, especially on the health side, and I'll talk a little bit about an article. But very important, again, as we want to study the longitudinal progression of a cancer patient, given the long tail that we typically see. There are also chatbots and automated follow-ups. Given the scarcity of just the healthcare workforce in our country, patients often struggle, right? When they have a side effect, how do they reach out to the doctor and who should they talk to? And so there's some of that can be automated, at least to triage only the more complex cases to the higher skilled professionals. And there are a couple of research applications, right? Once we have a lot of data, we can do population health studies. Even from a clinical trial standpoint, all of the manual process to match patients to clinical trials can now be very easily automated with clinical trial softwares that will match patients based on the exact study parameters that you want. This was the study that I was talking about. This was published in 2023, February, I think. There were a couple of researchers that looked at just the mobile health apps in breast cancer only, right? And they found, and this was only US and South Korea, they found 1,100 plus apps, right, that were available on Google and Apple Play Store on breast cancer, right? And they whittled that down with some analysis and assessment, and they eventually ended up with over 100, which they analyzed, and then 69 met their criteria. But the point is not that. The point is, that if you look on the right side, I won't go through the details, but essentially across the entire cancer care continuum, right, from prevention to detection, diagnosis, treatment, and survivorship, there are point solutions that are addressing each part of that cancer care continuum, right? And now I think clinicians over time, you can almost consider this as another tool, right, in your arsenal, that just like we prescribe medicines, there will come a day when you will start prescribing apps, right? In some of the Western countries, it's already happening. Doctors are actually getting paid to prescribe a mobile app on a prescription as a formal way of treatment. And it's complementary to everything else that we are doing, right? The challenge is even doctors don't know today which one is a good app, which is not a good app. And so there is work that needs to be done to assess some of these apps in terms of their actual outcome. But things are moving very quickly, and I think a lot of consumers, and we are all aware of the fitness apps, but there are very good apps that are specifically focused on, let's say, tobacco cessation, or even in breast cancer education and prevention, and doing a lot of other things. Okay, I'll shift a little bit to the National Cancer Grid. I'm assuming most of you would be familiar. It's an organization that is now has grown over 300 cancer care institutions across our country. It's run out of the Tata Memorial Hospital, Mumbai. And then last year, there was a recognition that despite all of the efforts that we are taking, the burden of cancer and the work that we need to do just keeps rising. And we need to have a focus on technology. So with that intent, was formed the Koita Center for Digital Oncology. It has the name Koita because of the generous donation of Mr. Rizwan and Rekha Koita, who are directors of the Koita Foundation. It's a non-profit organization that's focused on digital health. They've effectively endowed this organization for 5 years within the National Cancer Grid. But this is an organization that's solely focused on helping all of our NCG centers adopt digital tools and help them on their digital transformation journey. NCG itself is obviously a complex group in the sense that it's got large, medium, small size hospitals. It's got hospitals in tertiary, remote areas as well as in metro cities. So everybody's needs are very different. And the idea is to figure out what's relevant to what part of our community and bring that to them in a very consultative way. Because one of the findings that we had when we did an initial survey of all of our hospitals, that a lot of them lack the IT capabilities even to evaluate technologies, right? That the kind of IT talent that we have in hospitals are largely to run the hospital and the basic infrastructure. They're not very in tune with the latest developments in technology. And in the absence of that, doctors don't have the time to go in the market and search for what is the right digital tools. And so that's part of what we are focused on. So 3 broad focus areas. Again, it's a busy slide. Again, we'll not cover the bullet points, but again, you see the cancer care continuum at the top, right? Our first focus area is how do we help NCG hospitals in whatever technology initiatives they've already undertaken, right? Somebody's doing PAC, somebody's trying to automate the record keeping, somebody's trying to work on interoperability, digital diagnostics. They can come to us and seek help, seek our assistance in terms of how to go about that. And again, you see all these bullet points, right? There is so much work that needs to be done. These are all technology applications across the cancer care continuum. And each of these areas, you'll find multiple companies that are doing that, right? Just in breast cancer, there are a lot of companies that are now focused on low invasive thermal screening to detect breast cancer early as a replacement to a screening mammogram. And like that, there are many applications that are already underway. The question is, how do we curate that ecosystem and bring what's best to our NCG ecosystem? The second focus area is what we call as more of the common layer, right? In the sense that there is stuff that everybody doesn't need to reinvent. There are privacy security standards, there are interoperability standards that we can do at a national level, or at least at the NCG level, where any application, any software that needs to be built can then leverage that infrastructure and can only focus on the actual use case that they are trying to solve, rather than every company trying to build these blocks on their own, and then eventually you end up not having a synchronization between all of them. So we are working in this area. We are also working with the National Health Authority to ensure that what we do is very aligned with the ABDM architecture and what they are trying to accomplish. And the third area is none of this can be done without partnerships, right? We look at our role as the Center for Digital Oncology as an ecosystem enabler. We don't intend to build anything of our own. There are enough people building stuff. Our intent is to identify the best solutions that are applicable for specific pain points and bring them to the NCG ecosystem. and at the same time understand what each of our NCG member centers need and try to kind of marry them up. And for us, very important that we have good partnerships with health insurance companies, the digital tech side, even the more what we call as big tech, right? The Googles, the Amazons of the world, a lot of research that they are doing in technology, very, very powerful, right? And we have the benefit of having so much data. It's not structured yet, but once it does get structured, we have a lot of attention from these companies because they can't get that level of data anywhere else in the world, especially when it comes to cancer care. And we'll also work with government and state governments to see if there are certain programs that we can run for them, right, at scale. I want to talk about one specific initiative in a little more detail. This is the oncology EMR. When we did a survey of what do NCG hospitals need, right, as a priority in terms of digital health, what topped the table was that we need an oncology specific electronic medical record. That a lot of the EMR companies that are there, the electronic medical record is very vanilla, and that's how it was built. And so with that, what we did is we put a team together of oncologists and technology people, and they came up with a fairly robust set of requirements actually in the public domain. It's called the NCG EMR requirements. There are 200 plus requirements that an oncology specific electronic medical record should have. And that was published for feedback. We published a 2.0 version of that as well in around March 2023. With that, we actually went to the market and asked all of these EMR vendors to say that, can you commit to developing this in your product roadmap? Take your existing solution, which is already 60% there, right? But we will provide you with the subject matter expertise in return for whatever business you can generate from NCG. And we went through a very rigorous evaluation process to eventually empanel 6 vendors. So if you go to the NCG website today, you will find that there are 6 EMR vendors that are formally endorsed by National Cancer Grid as products that are building an oncology specific EMR. And again, we are not waiting for them to complete all of that. Much of the functionality already exists. But over the next 6-9 months, all of those vendors would have built the requirements that matches the 200 plus features that I mentioned. So whether it's virtual tumor board, we have actually subcommittees now that are working on, and some of the members of subcommittees are here, on medical, surgical, and radiation oncology to define very specific workflows. And by type of cancer, what are the data elements that need to be captured, right? So we have a team that's working only on breast cancer. We have teams working only on cervical cancer. So at least the top 5, we are trying to make sure that we are very clear on what clinical data do we need to capture at a minimum for us to achieve all the other goals. Similarly, we are also, as part of the EMR project, trying to standardize the analytics and reporting. Many of you who work in hospitals and work with hospital information systems, what we find is that there are so many reports everybody requests, and nobody uses that after some time, right? And so our idea is, can we standardize that analytics and reporting package that by and large meets the need of not just the clinical stakeholders, but even the management folks and the financial guys, so that the level of customization that is required continues to go down, and we move towards a little more standardized product. With that, we also launched what we called as LEAP, L-E-A-P, or the Leading EMR Adopter Program, to identify NCG centers who are keen to implement the EMR and can join the group or be the sort of leading adopters. The benefit for being a leading adopter is that NCG is actually funding the EMR implementation. Not in full, but if you take a 5-year cost, we are funding close to 40-50% of that cost, because we recognize that in a lot of technology implementations, the biggest barrier, right? There are many barriers, but one of them is obviously cost. And for a hospital, it's always a challenge between buying the next equipment or investing in technology. And technology is something that will give you value much later. And so everybody understands, okay, I buy the equipment, I put it to work, and I get value immediately. So the idea is that we are going to raise some CSR funding to help defray some of the costs for the hospital, so that the adoption of technology becomes faster. And that model we are going to replicate for everything else that we do. This is just for the EMR initiative. We already funded 4. We have 16 others that have applied for funding. We are just doing our due diligence to make sure that the commitment from the hospital is there to adopt the EMR, because that's really very, very important, that unless it's top down and people are going to sort of, I shouldn't say force your hand, but at least ensure that that level of motivation is there to use the EMR, then I think we'll start collecting that data in a much more uniform manner. So more to come on that. I think we are going to organize webinars very regularly now, so you'll keep getting these updates on what are some of our areas that we are working on. But one more slide, and I think, how much time do we have? Okay. These are the 3 broad areas right now that we've organized our work in. The first area is digital capacity building, right? What I mean by that is that unless we build the foundation, if we don't have EMRs, if we don't have good cloud connectivity, internet connectivity, which is still a challenge as you go to the interior parts of our country, how do you do a virtual skills lab, right? Training workforce physically is very difficult. People can only travel so much. But can we create a virtual environment where a lot of us are used to remote learning? Even the healthcare professionals can pick up that level of learning and upgrade themselves. So that's focus area number one. Second is the core work, right, which is to improve access to cancer care and quality. So after the EMR, the current work that we are doing, which we have not yet put out, is to figure out how to build a national scale telemedicine solution. And again, we've talked about telemedicine in many forums, right? And the jury is still out that it's not successful. Doctors don't like it because there's just too much time that is invested in a busy OPD. I can see 5 patients against one telemedicine call. And our belief is that I don't think technology is the problem. I think we've not figured out what the right operating model is. So we are spending a little bit of time to flesh out what the right model is for teleconsultation, not only in terms of how we'll do the teleconsult, but also which type of cancers and what kind of visits are better suited for teleconsult. And I think within around 6 months, we are going to do a couple of pilots. We will probably have a similar situation that we have for EMR, that we finalize the solution and we'll sort of roll that solution out to, again, reduce the burden on the apex centers from patients that don't have to travel all the way. And then there are obviously clinical decision support and patient engagement solutions we will work on as well. The last thing, and I'll end with that, is the cancer care innovation and research. And again, once, like I said, once the foundation is built and we start collecting the data in a digital format, having a national level cancer registry, which is more real time, and the fidelity of the data is much better. ICMR obviously is doing what they can do with the HBCR and PBCR, but a lot of that data is very manually intensive. And again, by the time it comes out, the relevance sort of goes down. So our idea is that it can auto-populate the cancer registry. And we are also trying to figure out that a lot of these startups, there are some wonderful companies that are trying to do very interesting things with cancer care. They always keep complaining that they're not getting enough feedback from the medical community. And if you talk to the doctors will say that, oh, technology people build what they think is right, but they never actually have lived the real world. And how do we bridge that gap, right? How do we identify solutions that are very good and hospitals that are very interested in certain areas and bring them together? So a lot of these companies see the light of the day. Otherwise, for lack of funding, eventually they all die. And so that's another area that we are going to start supporting some of these young organizations. And finally, we are also looking at building a good tumor bank that can allow more longitudinal research over time. So with that, I'll close. Any questions I'm happy to take, or if you're out of time,